want to welcome everyone tonight. Uh, Tonight's topic is on pre-hospital pain management, something that's very important in EMS and definitely of much discussion lately. Our presenter is Dr. Jeffrey Nusbaum, who I know well. He is the medical director for Baltimore County Fire Department, the assistant medical director for Baltimore City Fire Department, and also the assistant medical director for the Maryland ExpressCare transport ambulances. Dr. Nussbaum went to medical school at, what was it, Georgetown University School of Medicine. He did an emergency medicine residency at Mount Sinai Hospital in New York City. What I find even more interesting and valuable is he started his career as a volunteer in Bryn Mawr, Pennsylvania, which makes him awesome. So without further ado, I'd like to bring Dr. Nussbaum on. Welcome.
All right. Thanks for having me. I'm sorry about my voice here. I'm like day 7 of what I think is the flu. So if my voice cracks or I go through a coughing spell, I apologize. I saw lots of people coming in, some of whom I know well, others I don't know well. But for anyone who has a question while I'm going, I'm happy to stop and take questions as we go, and I'm happy to stay on in the end. If anyone wants to chat more about pain management or really anything at all. So without further ado, let's talk about pain. So because it's a MIMS talk, there are some objectives here. We'll talk about the importance of pain management, some pathophysiology, how to assess for pain, how to measure pain, and then talk about the Maryland protocols and maybe some future states of what the pain protocols will look like in a year or two. So why is this important? Obviously, sometimes we end up on scenes where people's ankles look like this, and treating this gentleman appropriately would be incredibly important. If this were me, I would hope that you would give me at least a liter of ketamine. I would hope you would put it in my shirt, all over me, in my eyes, everywhere. If my ankle looks like that, all the ketamine, please. Sometimes we're called to scenes that look more like this. And in these settings, obviously there's going to be injury or injuries, but also pain management is really important to help us with the extrication process itself. It's not just about getting the patient out quickly, it's doing it comfortably and doing it in a controlled fashion. And when someone is screaming and yelling at you because everything hurts, it makes working in a controlled environment very difficult. So pain management's important here. The other thing we face more now than ever is that when we get to the hospital, it's not like they're going to see a doctor and a nurse quickly at all. This is not an every minute of the day occurrence, but you all know that this is not uncommon, that a hospital actually looks like this, and you're just going to take a number, and your patient may be an hour, 2 hours, 3 hours till they actually see anyone. So getting them with appropriate pain management before getting to the hospital itself is so important. Untreated pain has significant consequences. So just being in pain itself is bad. You don't want to be uncomfortable, but there's actually physiologic consequences, and there's also consequences to the healthcare system as a whole. So untreated pain leads to adverse effects on hemodynamics, GI system function, and kidney function. Untreated pain causes tachycardia. It causes hypercoagulability. It can lead to cardiac complications, increased hospital length of stay, increased costs in terms of the cost of care, increased PTSD, and increased chronic pain. As you can see, there are real consequences beyond the pain itself to not managing and treating pain appropriately. So the summary of the first part is that pain is bad. So how common is pain in what we do? I looked up a bunch of studies and came up with a pretty big range of how common pain is. But there's some similarities here. So one study, 15% mild pain, 20% of pre-hospital patients have moderate to severe pain. Another study, about double that, 42% of pre-hospital patients have acute pain. Another study, 28% with severe pain. Another study, 30% of patients where the primary symptom or the primary reason for calling EMS was pain. And another study gave a very unhelpful 20 to 70% prevalence of pain in the pre-hospital environment. I can summarize that very easily and tell you that you guys deal with pain all the time. It's not just traumatic pain, it's abdominal pain, it's chest pain. Pain is really what we do. Unfortunately, though we treat a lot of pain and we come across a lot of people with painful conditions, unfortunately, we are not all that good at treating pain. One study of 4.3 million adults in England, so a little bit different ambulance system, they reported that only 36 to 40% of patients had meaningful reductions in their pain. That's pretty bad. That means not even half of the patients had a meaningful reduction in pain during their EMS experience. We'd all hope that we're a bit higher than that. In another study, which actually looked at physician-led teams, because a lot of ambulances in Europe are physician-led, 43% of people had insufficient pre-hospital pain relief. And again, you're over 50, you're nearly 50% of the people aren't getting appropriate pain relief while they're with EMS. Not great. What are some barriers to treating pain? Why might we be seeing these unimpressive results? So one of the main barriers is not actually assessing for pain. There's a lot to do in the back of the ambulance, starting IVs, charting, asking questions. There's lots of things that happen. So you might forget to ask about pain. Clinician bias and judgment is also a major factor here. The classic example would be someone someone with sickle cell disease, and you see them sitting there on their phone, and you're like, oh, they're not in pain. When in reality, they're in a lot of pain. And so these biases are both conscious and unconscious biases, and they really do exist. Especially in the Baltimore region, we worry about drug-seeking behavior. People think that people are calling 911 to access more and better drugs, and they're coming to hospitals in order to get drugs. I don't know how true that is, but it's certainly something that could exist. Maybe you're concerned about side effects. Maybe you're worried that pain medicine will make their blood pressure too low. Maybe you're worried that they'll get too sleepy for you. So these are real concerns. Maybe you're treating a vulnerable population, a kid, an older adult. Maybe there's a language barrier. It's hard to assess for pain when you can't speak the same language. Maybe they're obviously in pain, but they're altered, so it's difficult to actually have a meaningful discussion with them. Or maybe our toolbox is just too small because we really don't have a ton of tools to address and treat pain. The National Association of Emergency Medicine Medical Services Physicians, NAMSP, they have a position statement on pain, and I think it's really important what they say here. The most common reason is underestimation of the patient's needs. So we think we know what the patient needs, when in reality, we really don't. Again, apologies about this flu here. So pain comes in a number of different forms. Acute pain is loosely defined as any sudden onset pain that usually resolves in about 3 months or less. Chronic pain lasts greater than 6 months. You could think of chronic pain like back pain, arthritis pain. I'd like to think that we don't deal in the chronic pain world, but you and I both know that we treat plenty of people who are calling EMS for chronic pain. Kind of disappointing, but it is what it is. There are a number of different types of pains. So nociceptive pain would be like muscle pain, or somatic nociceptive pain would be like muscle pain, breaking a bone. Visceral pain would be like your liver expanding or your bowels expanding. If you have a small bowel obstruction, that would be visceral nociceptive pain. Neuropathic pain is due to damage of the actual nerves. Shingles would be the classic example of a nerve pain. You can also have peripheral neuropathy from diabetes or alcohol use. That can lead to pain as well. Ischemic pain is some of the most painful pain. That's kind of doesn't sound too great, but ischemic pain is one of the most serious types of pain we'll come across. The most common ischemic pain we see is heart attacks. STEMIs would lead to ischemic chest pain. We also sometimes see ischemic bowel, but that's much less common. And then there's referred pain. So that's pain that's felt in a different location from the actual source of the pain. The classic example would be gallbladder pain, or when you have cholecystitis, you sometimes get pain up in your right shoulder because your gallbladder is irritating the diaphragm, and it's being felt up in the shoulder. So that's referred pain. Pain travels in the body from the peripheral nociceptors down here. It goes through the peripheral nerves into the dorsal root ganglion, up the spinal thalamic tract into the brain, and then the pain signal travels back down into the spinal cord, and you experience the pain signal. Because it takes this huge pathway, there's a lot of different places we can address the pain itself. We can use local anesthetics and anti-inflammatory drugs to target pain at the tissues, the injured tissue directly. We can use local anesthetic in the form of nerve blocks if you go to the peripheral nerve itself. In the spinal cord, you can think of like an epidural. You can use local anesthetics or opiates or alpha-2 agonists, and then you can use opiates or alpha-2 agonists and other pain modalities as well to target pain in the brain. These are a lot of fancy parts of the brain that I don't think you really need to worry about knowing every part of it, but pain is complicated, and pain has a lot to do with how the pain signal is processed by the brain itself. Therefore, because pain is processed in your brain, there's a lot of factors that influence that processing. So what actually happened? The insult itself is a big part of the perception of pain. Maybe age plays a role. You know, my 3-year-old bumps his toe and it's the end of the world, whereas my 6-year-old, it's not a big deal. So that influences the perception of pain. Comorbidities, you know, do you have poor tissue healing? Do you have a lot of other conditions that make it more difficult for you to cope with pain? Mental health plays an enormous role. If you're already depressed at baseline, having something painful happen to you might make it even worse. Expectation, beliefs, mood, attitude, attention. So some cultures, pain is understood as it's just going to happen, and that's okay. Other cultures think we should live in a pain-free society, and those two different groups would have very different perceptions of the pain itself. Cultural norms, social support. If you're by yourself, it's a little bit, if you have no support at all, things tend to hurt more and you have difficulty coping. We'll talk about culture in the end on one of the last slides when we talk about fracture management in different countries. So pain is complex. There's lots of targets for pain, and treatments need to be tailored to the patient in front of you, not necessarily generically by a protocol. How do we measure pain? So in this same position, NAEMSP position statement, they have a couple important statements on measuring pain, which I will just read to you because they're really important. The ideal instrument for pain assessment should allow for the identification, presence, and intensity of pain, as well as the change in pain severity with time and treatment. In general, one-dimensional pain scales are easy to complete and therefore the most frequently used instruments. The most common scales include the numeric rating scale, the visual analog scale, and the verbal rating scale. The key is to just ask the patient if they have pain. So frequently the need for analgesia is unrecognized because the patient is not questioned regarding his or her pain. Patient self-reporting is the most reliable indicator of the existence and the intensity of the pain. So you must ask the patient if they're in pain. You can't just rely on what you're seeing in front of you. And that is a really important point. You know, we can't just say, oh, your vitals are normal, you look good, you're not in pain. They usually called the ambulance because of something painful. And as I mentioned before, it's like almost 50% of calls actually involve pain itself. This is the verbal pain intensity scale. Nothing too complicated here. It goes from no pain, mild pain, moderate pain, severe pain, very severe pain, and the worst possible pain. You basically give the patient a choice and say, how bad is your pain? And they choose one of these markers. The numeric pain rating scale, very simple. 0, no pain. 10, the worst pain ever. We know that every patient that we encounter has 100 trillion out of 10 pain. That's basically standard in Baltimore County. You must have greater than 10 pain if you're calling 911. The Wong-Baker FACES pain rating scale is for people who have trouble communicating. You basically match how painful your condition is to the appropriate face. Maybe these are emojis now, but I guess you go from a smile to a frown with some tears. This is especially good for young children who have trouble communicating. Visual analog scale, very similar to the other scales we talked about. Again, you go from no pain to the worst possible pain, the 100 trillion out of 10 pain, and you just put an X or you put a dot where on the scale your pain is. Very, very similar to 0 out of 10. The FLAC scale, the FLAC scale, or the face, legs, activity, cry, consolability scale, is a tool that's used to assess pain in children and nonverbal adults who cannot communicate their pain verbally. This is nothing you have to memorize, just something to be aware of that's out in the world. The CPOT scale is something we use in critical care transport. This is the critical pain observation tool. So it goes from 0 to 8, where you can get 1 or 2 points in every category, or 0 points. You measure the facial expression, whether it's relaxed or neutral, or tense or grimacing. You look at body movements, you look at muscle tension, and then you look at ventilator compliance. So are they able to be ventilated easily? Are they coughing on the ventilator but doing okay, or are they fighting? So this is how you measure pain for intubated and sedated patients. But back to the Maryland medical protocols and what we're here to talk about today. So the Maryland medical protocols endorse 2 different things. They endorse the 0 to 10 scale, with 10 being the worst imaginable pain, or the FACES scale, which again goes from smiley face to frowny face with some tears. For peds, it's the same thing. You can do 0 to 10, and then again, you use the FACES scale with the smile to the frown. So measuring pain, takeaway. So takeaways from this section. If there's pain or the possibility of pain, you need to measure it. How you measure it is really not that important, but what is important is that you actually measure the pain itself, and you need to reassess frequently, especially when you're treating the pain. You need to measure the response to the treatment you've delivered. So ask about pain, measure the pain, and then treat it and measure it again. Speaking of treating pain, we'll start with non-pharmacologic treatments first. So these treatments are so important. You know, fentanyl, treating pain with fentanyl and ketamine is very sexy, but it's probably not quite as important as all these non-pharmacologic things. Splinting, ice, movement restriction, distraction, all these things are so important to minimize any worsening of the pain, but also they're risk-free. You know, nothing we do in medicine has no risk, but elevating an injured part or compressing it is essentially risk-free. And we like treatments that have high benefit and next to no risk. So we should be using non-pharmacologic pain management as much as possible. And I think it's often forgotten about. You know, with BLS crews, it's easy. I bet a BLS crew will never forget an ice pack, whereas an ALS crew might be a little bit more likely to forget it because they're doing something like starting an IV and giving fentanyl. Reassurance is also really important. Just talking people through the condition itself will help alleviate some of the pain. If you've had the pleasure or excuse me, if you've had the pleasure or unfortunate, or if you've had the pleasure of being in a good pediatric ER, but unfortunately, if you've had a patient or a family member who's in the pediatric ER, you'll notice these people that they're called child life specialists. All pediatric ERs have them. They usually see the patients before the doctors and the nurses, and they have so many tools to help distract kids. You could see this kid here with, I don't know what's wrong with him, but she's teaching him about shots, giving the bear the shot. This is very common, and it's very effective in helping quell anxiety. I'm not suggesting that we need to hire a child life specialist to go on the ambulance. I'm not suggesting that we should get fake doctor kits to go on the ambulance, though I probably have about 3 for my kids that I could bring if we want. But this sort of distraction is so important, especially when you're taking care of kids. In the BLS protocols for pain management, there's really only one choice with that, which would be acetaminophen. It comes in a suspension form or 2 325 tablets. Acetaminophen, we're not exactly sure, or Tylenol, we're not exactly sure how it works, but we know it's an inhibitor of prostaglandin synthesis. We know it doesn't really help inflammation, but we know it helps pain, and we know it helps terminate fevers. In the ALS section, we have a lot more choices. We have fentanyl, morphine, ketamine, and toradol or ketorolac. Fentanyl is an ideal drug for EMS with an onset of 1 to 2 minutes and a half-life of 30 to 60 minutes. It's really perfect for the length of transport and the length of time that we're with much of our patients. Very importantly, fentanyl has little to no hemodynamic effect. You might get a little bit of hypotension from it, but it's pretty small. And especially in comparison to morphine, there's little to no hemodynamic effect. Similarly, Fentanyl, unlike morphine, there's almost no vomiting or no nausea that comes with it, and there's no histamine release, which is very common with morphine, which is why you see hives and itching, and people often request IV Benadryl when they're getting morphine in the hospital or with EMS. Fentanyl is a synthetic opiate. It acts in the periphery on gamma receptors. It acts in the spinal cord on kappa receptors, and it acts in the brain on mu receptors. It's important to note that though I went pretty quickly by it, the actual preferred delivery of fentanyl in the Maryland medical protocols, the preferred delivery route is intranasal. I put something in the newsletter a couple weeks about this. We certainly do see intranasal fentanyl in our charts or in our care, but it's not that common because I think most of us go right to the IV. But the Maryland medical protocols actually want you to be giving intranasal fentanyl. The reason for this is that the absorption is pretty good. And it's fast. You know, if someone has a painful condition, it is a lot faster to squirt something in their nose than set up for an IV, start the IV, drop the fentanyl, and then administer an IV. I'm not saying that everyone needs to have intranasal fentanyl, but it is something important to think about, especially, you know, if there's a lot going on, it can be very easy to just give a dose of intranasal fentanyl and then go on with all the other things that are happening in care. Especially if someone's entrapped in a vehicle or something like this, intranasal fentanyl would be very efficacious. You can see here, this is the nasal anatomy. Most people, when they put things in their nose, go straight up, like up towards their brain. And that's not the right way to administer fentanyl, administer anything intranasally for pharmacologic interventions. You want to go straight back, like following the top of the mouth, essentially following the roof of the mouth, so that you can get the drug here where it will have the most chance of being absorbed. Morphine is another choice in the Maryland medical protocols for moderate to severe pain, so 5 to 10. Morphine has a pretty fast onset. Fentanyl is 1 to 2 minutes. Morphine has a 5 to 10 minute onset. Morphine's half-life is a little bit longer, 2 to 4 hours. In Baltimore County, we don't have patients for typically 2 to 4 hours, but there are plenty of jurisdictions in Maryland where they transport quite far. You know, if you're coming from northern Cecil County down to a trauma center, you're going to be with the patient for quite some time. Morphine does cause a little bit of hypotension. Morphine also causes histamine release. That histamine release causes people to get nauseous, vomit, and also have some itching. Ashley or Dr. Sagal, I saw there's some things in the chat. Oh, okay, sorry. It's just the sign in. Morphine used to be part of the standard management of chest pain. You might remember the Mona morphine oxygen nitrates for every patient with chest pain or every patient with a STEMI. Morphine has really fallen out of favor in treating patients with chest pain because when people get to the hospital and they're having an ST elevation MI, some of the anticoagulants we give them, Plavix and Brilinta, their metabolism is affected by morphine because of its histamine release and some of the biochemical reactions. So morphine has completely fallen out of favor for managing people with STEMIs and chest pain. Ketamine is probably most people's favorite drug just because it's new and it's sexy and it's very efficacious. Ketamine is a non-competitive antagonist of the NMDA receptor. Ketamine has a very fast onset, again, something like 1 to 2 minutes, and a pretty quick recovery afterwards. A single dose of ketamine will last something like 20 to 30 minutes. Ketamine is incredibly important because it's opiate sparing. You know, in the modern society, we use opiates for just about everything, and we have a major opiate problem here in Baltimore. So there are plenty of people who might not want opiates, and so ketamine is opiate sparing. Ketamine is an interesting drug because at the lower doses, the analgesic doses, you only need to give a little bit. As you move up and you give more, so something in the 0.5 to 1 milligram per kilogram range, you get into this partial dissociation realm, which is actually a little bit dangerous and it's very unpleasant. So ketamine, if you've ever seen someone in a quote unquote K-hole, their eyes flutter, they're looking off. I usually tell people they're going to see unicorns and Lamar Jackson riding unicorns out into the wild. And so if you're going between the unicorn land and then down back to reality and then in and out of this partially dissociated world, and you're going back and forth, it can be very, very like scary, and it can be very disorienting, which is not what you want in one of these scenarios. So partial dissociation is actually really potentially quite harmful. And then beyond that, 1 milligram per kilogram and above, you get full dissociation. That's usually what we use for the intubating dose or the severe agitation dose. Ketamine has real side effects that you need to be aware of. We don't see it that often because we don't push ketamine very fast because people have been trained to do this appropriately. But if you were to take ketamine in a syringe and push it as hard as you could, as fast as you could, you have a real risk of laryngospasm. Um, Laryngospasm occurs, you can see the normal vocal cords that are wide open there. Laryngospasm causes your larynx to spasm and your vocal cords to slam shut. Laryngospasm is immediately life-threatening, and it's quite terrifying. I've only seen it from ketamine administration one time when I was a medical student at Georgetown. I went to the operating room, and I was pretty sure the kid was going to die. And the anesthesia resident who I was with, also was sure the kid was going to die. And the attending walked up and immediately broke the laryngospasm, and everything was quite fine. But it's very terrifying because you start desatting very quickly, and you need to break the laryngospasm. So how do you break laryngospasm? So you can do it a number of ways. You can press on the laryngospasm notch. Um, this can be referred to as Larson's maneuver. We're putting pressure just behind the angle of the mandible in front of the ear, causes that laryngospasm to break. You could also try a very aggressive jaw thrust that may break the laryngospasm, or you can use the BVM. If you are going to use the BVM, this isn't like a gentle BVM. You have to squeeze the BVM incredibly hard to actually push air through the vocal cords. This is going to require a true two-person BVM. This isn't just like, nice one hand, half the bag. This is a humongous amount of pressure, and it really does require two people, just like these gentlemen are doing here. Interestingly, in the Maryland medical protocols, ketamine is indicated only for musculoskeletal and back pain, and it is contraindicated for chest pain, abdominal pain, flank pain, and headaches. We've had a number of cases recently where ketamine was very reasonably administered by very thoughtful EMS clinicians, but they were all technically protocol variations because we gave it for people with other traumatic injuries that wasn't just musculoskeletal pain and wasn't just back pain. I wasn't around in 2019. I wasn't in Maryland in 2019 when ketamine came into the Maryland medical protocols, but I believe the reason that ketamine is not indicated in the Maryland medical protocols for chest pain and abdominal pain is that you could have an aortic aneurysm, either a thoracic aortic aneurysm in the chest or an abdominal aortic aneurysm in the abdomen. If you have an aortic aneurysm and you would give ketamine, ketamine increases your blood pressure and it causes tachycardia. Those are the two worst things if you have an aortic aneurysm, and would almost certainly lead to sure death. And so I think the authors of the pain protocol, when ketamine was added, were afraid of people giving ketamine to people with aortic aneurysms or aortic dissections. I think that is the reason it's not indicated. In the case of the headaches, if you have an acute onset headache, there is a chance you have a subarachnoid hemorrhage. When you have a subarachnoid hemorrhage, increasing blood pressure, increasing pulse is bad and can lead to worsening of your subarachnoid hemorrhage. And so therefore, ketamine potentially could make your subarachnoid hemorrhage worse. There is an old thought that ketamine leads to increased intracranial pressure. That has essentially been debunked. There was actually a very good study out of Florida where they measured intracranial pressure with pediatric patients who had intracranial pressure monitors in, and they gave ketamine and watched the pressure, what happened to their intracranial pressure. Ketamine actually decreased intracranial pressure. So the myth that ketamine increases your intracranial pressure has almost been completely debunked. The last drug that's available to you all in the Maryland medical protocols for treating pain is Toradol or ketorolac. This is an NSAID. It's more effective than other NSAIDs. It inhibits the COX-1 and COX-2 enzymes. Its half-life is 5.6 hours. So that's excellent because it will last throughout their entire ED visit. And it is very, very, very efficacious. Uh, if anyone's ever had a kidney stone, I don't wish it upon anyone. I've had two. They're very unpleasant. Ketorolac will almost instantly take away kidney stone pain. Ketorolac is also excellent because it will reduce your opiate requirements, and it's essentially synergistic when used with other medicines. So you can give this NSAID. Again, it's not very different than Motrin, except it's stronger. You can give this NSAID, and all of a sudden you're using less opiates, which is wonderful. In one study of patients with postoperative pain, ketorolac was equally efficacious to morphine, which is quite remarkable if you think about it. Couple quick asides here on pain management. When I was in medical school, and I was actually talking to Dr. Chismar about this before, uh, we were taught initially or back in the day that using one pain medicine or using one medication is the appropriate strategy. Unimodal analgesia is the appropriate strategy because you don't want to mix things. When you mix things, you're going to get all these random side effects, and they're going to start acting on each other, and then you don't know what's going on because there altered mental status from mixing things, or is it from something that's actually happening? So if you use just one drug, you can titrate it up, and you can do that until you've quote unquote maxed out the dose of that drug. Then you move on to something else. This is the old style of pain management. Nowadays, most, um, Dr. Sagal could probably tell you more about this, but most anesthesia pain services prefer a multimodal approach. So, what's a multimodal approach? A multimodal approach is that you target all the receptors simultaneously. You give a little bit of several medications instead of a lot of one medication. In this way, you're hitting all those receptors I talked about before. You're hitting the peripheral tissue, you're hitting the nerve, you're hitting the brain. And by hitting all these different receptors, it doesn't take a lot of any of the medicines to really make a good effect. Also, you get synergy. If you use Toradol and morphine, it's a lot better than just a lot of morphine. So you can see these are all the different types of pain management that's out there. If you combine them all, you really might come up with a cocktail that's quite good for treating acute pain. Some special populations to think about. Here in Maryland, in the Baltimore area, um, we have quite a few people that suffer from opiate use disorder. These people present a unique challenge. So some people who have opiate use disorder want no part of opiates anymore. They've gotten clean. They don't want anything to do with opiates. Giving them a dose of fentanyl could lead them to relapse. For them, you should consider ketamine or Toradol. The other thing is if somebody is actively using fentanyl on the street, when they have a painful condition, and they're more than likely to have many painful conditions, 100 micrograms of the 1 per kilo dose of fentanyl is not going to be enough for them. Their tolerance is going to be ridiculous because they use opiates all day, every day. So one dose is not going to be enough. Some people with opiate use disorder are on buprenorphine, which is a partial agonist of the mu receptor. And if you're on buprenorphine, you can absolutely give other opiates. The only thing you need to remember is that you need to give a lot of opiates. So again, the 1 per kilo of fentanyl is not going to really have any effect on them, and you're going to need to be much more aggressive. Another special population to consider would be the autistic kids. So we don't encounter them so often, but um, one of the main things we worry about with ketamine when giving ketamine to autistic children, and we do this a lot for conscious sedation in the ER, is that autistic children respond quite a bit to sense. They're very sensorial beings. Their senses are hyper aware, hyper acute, and so when you come out from your ketamine high, when you're done with ketamine, many autistic kids experience what's called an emergence reaction, where you like re-enter the world in a very dramatic way. And so you have to be very aware that this can happen to an autistic child or an autistic adult who's getting ketamine. The best way to make this not happen is to pre-treat with a benzodiazepine, like Versed in our case. This is not really important for the Maryland medical protocols, but it's something to consider because this can be very frightening for an autistic child who's treated with ketamine when the drug actually wears off. We had in Pittsburgh, um, there was a like 22-year-old autistic kid who dislocated his shoulder a lot, and a lot of paramedics got very surprised when he came out of his ketamine emergence reaction. He was just going wild, and it was not very fun for anybody. The last special population to note are the elderly. The Maryland medical protocols really ask, they really tell you you should give 1 per kilo. They don't really, there's no way, strictly speaking, to give less of something. No one's going to ever be upset that you gave 0.5 per kilo. But the elderly might be very sensitive. Last night I was working in the hospital, and we had two patients, two 90-year-olds who fell and had head bleeds. A 90-year-old who falls is going to respond in quite a robust way to fentanyl, especially if they're fentanyl naive, which is often, unfortunately, not the case in Baltimore. But you have to just be very aware that the elderly might be extra sensitive to the medicines you're offering them. A note about self-rescue. So we have quite a bit of wilderness in Baltimore County. You don't see it a lot during the winter, but when the summer months come back around, you're going to see you'll see quite a few rescues go out where someone is lost in the woods or injured in the woods. One of the tenets of wilderness medicine is that if the person can assist with their own rescue, if the person can help you rescue them, you will be a lot better off. You can see this lady on the left there with her ridiculous leg splint. She's probably in a good bit of pain, but she's able to assist those two gentlemen in getting her out of the woods. Versus the person on the right who's in that Stokes basket completely tied up. It's going to take, like, I don't know, 2, 4, 6, 8, 10 different people to get that person out. So if you can treat the person's pain and get their pain under control to the point that they can assist you with their rescue, they're going to be, everyone will be a lot better off, both the patient and the rescuer. Now, you can't give someone so much ketamine that they can't walk, but you might be able to give them a dose of fentanyl to take the edge off, so that you would be able to have them help you with their own rescue. The other thing that really irks me a lot is that people often say, well, their blood pressure was borderline, so I really didn't want to give them pain medicine. That is the wrong approach to this. So if you are saying their blood pressure is borderline, and you're afraid to give them pain medicine, what you're saying is you like the fact that their endogenous epinephrine, that pain is increasing their epinephrine, which is increasing their blood pressure, and you're afraid if you treat their pain that epinephrine surge is going to go and their blood pressure is going to go down. We do not want to use pain as a vasopressor. We have great ways to address low blood pressure. We have fluids, we have epinephrine drips, we have plenty of ways to address low blood pressure. We should not allow patients to suffer because we're afraid of low blood pressure. We do not want to use pain as a vasopressor. Sorry, I just saw there's something in the chat. Oh, yes. Carol mentions that redheads require more anesthetics in pain medicine. Dr. Sagal, yeah, that does tend to be true. My wife looks like she has blonde hair, but all the anesthesiologists in the OB world that we've interacted with have said, yo, you're probably actually a redhead because it takes more analgesia for her. Should we consider diluting the fentanyl for pain management in the elderly, from Jess Hayes? I don't know that there's value in diluting it. Maybe give it a little bit more slowly. I would say you can give a half dose and check and see if you're getting a good response, would probably be the best way. And then I'll talk about in the next slide as well, Jess, what I think might be the better approach. And then Dr. Sagal points out that Toradol might be the better choice for the elderly. So again, back to the pain as a vasopressor. Don't let low blood pressure scare you away from treating pain. Give them IV fluids. Someday when we have blood, give them blood. Give them an epinephrine drip. But don't use pain as a vasopressor. What does the future hold for pain protocols? Formerly, IV Tylenol was incredibly expensive. In the hospitals, hundreds and hundreds of dollars per dose, and therefore it was restricted basically only to the anesthesia world in very specific circumstances. IV Tylenol has now gone generic, and it's gone down to about $19 to $20 when I checked the other day. Now, oral Tylenol, a dose of oral Tylenol is like 3 cents, so it's still much, much, much more expensive. But IV Tylenol may be an option in the future to treat pain. The IV Tylenol literature is interesting because half the people think it works as well as oral Tylenol, and half the people think it's God's gift to medicine, and it makes all the problems go away. In residency at Mount Sinai Hospital, all our hip fractures got IV Tylenol, and they swore that's the only medicine they needed because it was so efficacious. So I think in the coming years, you'll probably see IV Tylenol in the Maryland medical protocols. I think you will probably also see multimodal analgesia. Right now, the protocols pretty much limit you to choosing one pathway, and then you would have to consult to change to another pathway. There's so much good reason to choose two agents, target multiple receptors, attack the pain from multiple different ways. I think the future state of the Maryland medical protocols, and Dr. Chismar and the protocol review committee, if they're on here, I don't know their appetite for it, but I think you'll probably see multimodal analgesia coming into the protocols in the near future. And lastly, I think you're going to see some shared decision making as well. So shared decision making is when you discuss with the patient the pathway, the treatments of choice. You know, medicine used to be paternalistic. The doctor tells you to do something, you will do it. Now we involve the patient in all their decisions. So I think the same is going to be true for paramedicine or ALS clinicians. And I think in the future, you're going to just ask the patient, what would you like to treat your pain with? Are you in severe pain? Would you like fentanyl? It's a very potent narcotic. Or do you want to try something that doesn't have that same effect? It's not going to make you as loopy, but it might take the edge off, like IV Tylenol, like Toradol. You want to try a half dose of fentanyl and some Toradol. I have this drug called ketamine. Ketamine's pretty new, and it should alleviate your pain, and it doesn't use opiates. So I think in the future you might see some shared decision making when it comes to pain management. Someone asked about the green whistle for BLS. Yeah, I mean, it's not really used in the United States that often. I wish we had it. I wish it was more common. I wish nitric oxide was also more available because it's so easy to use. You just put a mask on the patient. This is what they do in Australia and in London.
Nitric oxide, not nitric. They both
nitrous oxide. Sorry, what did I say? Nitric?
Yeah, nitric. Don't do that.
Yeah, nitrous oxide. Yeah, nitric oxide's for something else. Nitrous oxide is a potent pain medicine, but the good part about it is you can't really overdose on it because it's self-administered. So you have to hold the mask on, and when you hold the mask, if you get if you've taken too much of it, you will drop the mask, and then you will return to reality. The problem with nitrous oxide is that the tank is heavy, it's expensive, and so it's not really practical. So practical for most EMS agencies. A note about culture. So I mentioned that I would talk about culture later. This is fascinating to me. So in America, when you break your arm or you break anything, you can expect to get an opiate prescription. One of my college roommates, a med school roommate, he's an orthopedic surgeon. He standardly would write prescriptions for 60 oxycodone. And I always asked him, like, why would you do that? And he was like, well, they're going to be in pain. I don't want them to call me. So he would give some outrageous amount of oxycodone for a fracture. And this has become normal in America. We expect to get opiates for pain. It's just what people want. It's what they need. It's what they expect. This is normal. This is the Children's Hospital in Melbourne, and they talk about this is their fracture management page. This is for all fractures in kids. And you will note that analgesia first, reassurance and education, and splinting. Those are the three tenets of their pain management. But if you look in the analgesia section, they say that pain relief can be provided by paracetamol, which is essentially Tylenol, or diclofenac, which is essentially Toradol. So the standard of care in Australia for fractures are not opiates. It's actually Tylenol and ibuprofen, which is remarkable that, those people in Australia are the same type of people that we are here. It's just culturally in America, we have come to expect opiates as the standard of pain management. In other countries, they're not walking around in more pain. I guarantee you they're not uncomfortable. They're culturally, they know that once they take that edge off, that's their expectation that, yes, I broke my arm, it's going to hurt a little bit. And so I'm going to take these two medicines and I'll be just fine, which is fascinating to me how culture plays such an important role in pain management. This is one of the rescues we were called to about 2 years ago, I believe. I tried to find the exact picture. I'm not 100% sure if this is the rescue, but when the box truck went across the road on I-83 up in Haverford, and the guy was heavily trapped. He was 300 or 400 pounds, I believe, and we just could not get him out. And so that was a really, Carol points out that the orthopedists don't initially recommend NSAIDs for fracture. Carol, there is some studies in rats that NSAIDs may inhibit bone healing. So the orthopedists think that their patients could be rats, and therefore they don't recommend NSAIDs. I think I think that you're right. They don't do that, but because of the fact that we're humans and not rats, in at least in Australia, they think NSAIDs are fine. How significant is the bleeding risk? The bleeding risk is not nil. The Maryland medical protocols limit it mostly because if you do have internal bleeding, it would be poor form to give Toradol and then have them bleed worse. It's also, some surgeons don't like operating after the patient's been given a dose of Toradol because their field gets very bloody. That's somewhat debatable depending who you talk to. But yes, for acute undifferentiated chest and abdominal pain, there is a real risk in giving Toradol. Orthopedists love it for post-op pains. Dr. Sagal points out. So yeah, it's really hit or miss. But the literature, there are rat studies that show that NSAIDs do inhibit bone healing in rats. So that's not for nothing. Sorry for this distraction here. But so in this call, this gentleman was so trapped between his seat and the pallets that were in the back of his truck that the pallets slammed into him and pinned him, are basically wrapped around the tree. Lieutenant Drew Williams was first, and then the Maryland State Troopers were second. They treated this guy's pain very aggressively. I think he got probably 4 or 5 doses of ketamine, pain dose ketamine, while we were undertaking the extrication. It was a really long extrication. I don't know, 30, 40, 50 minutes, maybe an hour. It took forever just because of the way he was trapped. And it was so important that we kept him calm and kept him pain-free. So that was an excellent use of analgesia to facilitate the rescue. This was a subsequent call much lower down on I-83, where the trash truck went into the back of the medical supply truck. In this call, I often talk about facilitating, using pain medicine to facilitate the rescue. In this call, it's simply what wouldn't have been possible. This gentleman was obtunded. Though they could have gotten to his nose, they had no reliable way to measure vital signs. They had no reliable way to monitor him. It would have been very, very, very unsafe to be offering pain medicine in an essentially unmonitored situation. So it's not for all patients, it's not for all rescues, but it is something to keep in mind. I truncated this presentation because I knew my voice was going to go out as it is. So we're going to end here in just under the hour mark, and then I'll take some questions. So from the beginning, you should recall that pain in the pre-hospital environment is pervasive. How pervasive is pain? I'm not sure, but it's probably about at least 50% of the calls we go on have something to do with pain. Pain is grossly underrecognized, and it's often underrecognized because we simply don't ask. It is so important to communicate with your patients and ask about pain. Pain should be measured. It doesn't really matter how you measure it, but pain should be measured, and you should measure your the response to the medicines you're giving or the interventions you're doing. Pain should be treated using shared decision making. We shouldn't force people to have fentanyl because they have severe pain. If they want Tylenol, they should get Tylenol, as long as it's you think it's a reasonable decision. You should use all of the tools in your toolbox, and use the patient's cultural preferences, the patient's condition, their history. If they have opiate use disorder, if they're on buprenorphine, you should take all of that into account. Hopefully, in the future, you'll see IV Tylenol and multimodal analgesia, so the toolbox will get even bigger. And with that, we're going to end just a little bit early again. Apologies about my voice and my sickness here. Happy to take any questions if anyone wants to share their experiences or thoughts or concerns.
Thank you for your presentation. It's interesting the way things have evolved in Baltimore County over the decades. I've been doing this for a long time. I remember when I was a brand new physician, I had a patient who had a femur fracture from a motorcycle accident, and I gave him uh, kind of morphine to help his pain, which it didn't do as much, but that was the only drug we carried. And one of the field supervisors wrote me up. The medical director at the time was Dr. Frank Branco, and I remember him saying, "You guys just gave him 10? Did it do anything?" And it's like, we only carried that much. But it's definitely evolved. I think the future is basically going to be multimodal as it comes about, because that's going to be the best of all worlds. And we're getting it. We already have some of the stuff. I mean, we carry ketamine, we carry Tylenol, we carry aspirin, even we carry Toradol, we carry morphine's available. It's all there. So it's interesting to see where it goes, but I think it's going to go further. I don't know about nitrous oxide, as I see in the comments on an ambulance, because it's heavy, it's expensive, and you have to have certain controls because it's considered an atmospheric pollution. Anything more than 25 parts per million in the air you breathe in for everybody around it. So I don't think they'd be happy with it in the back of the ambulance at the moment. But I
Uh,
think carry
I,
it's
I think there will, I wouldn't be surprised if we saw it someday. Yeah, everything in medicine is like a pendulum. So before we wanted no one to get opiates, and now everyone gets all the opiates, and now we're starting to go away from opiates. So I wouldn't be surprised if the pendulum swung to nitrous oxide. The issue, as you say, is cost and weight. It's just it would be a challenge for many of the jurisdictions um, to have it. In Baltimore County, 55 ambulance, it would be so expensive for us to get it on every unit. And honestly, the tools we have are quite efficacious. But yes, I agree, especially for the BLS level, it would be a very nice tool. And someone mentioned before the green whistle. I mean, all of these things are fairly safe, easy, and um, really would enhance the care we provide. A lot of times we forget that we're providing care, and we mostly focus on the transport aspect of what we do, but we're there to provide care, and appropriately managing pain is one of the most important things we do. And so, I would not be terribly surprised if to see nitrous oxide become a little bit more common.
one of the things we do in the hospital when we use ketamine, which we don't do in the field really, is we give a little medaz with it first, because it will help with some of the side effects of it, especially the nightmares or the illusions that they might soon see. But that's not part of the protocol for the ambulance.
Yeah, unfortunately, someone mentioned that Toradol decreasing renal blood flow. So yeah, Toradol or ketorolac really does work on the kidneys. It if you I can't speak to NFL players' lawsuits as you mentioned, but if you were profoundly dehydrated, giving Toradol will be a big problem,
Yeah.
and so that's probably what you're referencing.
Well,
Um,
the other thing is Toradol it's really, you shouldn't be using it for more than 5 days, and then you should stop. just because of the renal side effects of it. And I'm thinking your little NFL players are taking it a lot more than 5 days, and that's where you start getting into trouble.
Yeah, someone mentioned in the chat, can we give Midaz with ketamine? By the protocol, no. You would have to consult and have the physician agree with that. I would shy away from it, mostly because typically we're giving the pain dose ketamine, and you see less of the emergence with pain dose versus the dissociative dose. Certainly, if you want to consult and discuss it with a doctor, it's reasonable, but you would have to do it with consultation. And if anyone wants to look into it, the IV Tylenol is quite amazing because there are two camps with IV Tylenol. The camp where they say it does nothing, and the camp where people swear by it. I am going to be working on revising the pain protocol, and we'll see if we can get IV Tylenol in the ALS pharmacology section, and we'll see. We'll build our own intuition. We'll build our own experience with it. I think it's a nice tool, and again, I think it's something that will help limit opiates. We certainly do have an opiate problem in Baltimore and in America, and so I think anything we can do to shy away from opiates is potentially a really good thing. And so I'm hopeful that we can push this through the next protocol review committee next year, and then it'll be an option for us as well. $20 per dose is expensive, but it's not it's not that expensive on the grand scheme of things. Every tourniquet is like $80, so
What
$20
is
is
ketamine
not
cost?
that bad.
What's the county cost for ketamine right now?
Captain Glaze is on. She might know better than I do. I don't really know.
It's expensive in the hospital.
It is
More
pretty expensive, and I think, yeah, both concentrations, maybe for a box of 10, like $600 or $700, maybe. It's pretty expensive. Yeah.
about the hospital price is just a little bit less than that, but we buy a lot more. So I think the Tylenol is reasonable, and we could always petition MIMS to do it as a local option or as a project to see for validity. I don't see why they would have any issues with it.
Luke wants to know any tricks of the trade for intranasal fentanyl while supine. I wish I had something profoundly smart to say here, and I just don't. It's hard when they're laying flat. I'd probably give it to them when they're more upright. Now that we don't put everyone on backboards, we have less people that are fully supine, so there might be an opportunity to sit them up. I got nothing for you though. Sorry.
I would give it IV maybe. If I didn't want them bucking.
All right. Well, I know we had 2 hour spot. I shortened this because of this flu I'm battling here, but thank you all for your attention. Definitely feel free to reach out with any comments or concerns. I look forward to some changes in the protocol, and thanks to Ashley Pikesville and Dr. Sagal for continuing this amazing series, and for all of you guys for tuning in on a random Thursday night here. I'm sure there's plenty of great things to do, and you're listening to people talk about pain. So appreciate your time and your attention here. I'll hang for a little bit longer, but feel free to jump off.
If you look in the chat, there's a link if you would like to get MIMS Continuing Ed. We will return with the next topic in 2 weeks from now. We are fully booked for the next season, so I look forward to much opportunity for learning and sharing of knowledge. Thank you so much for coming tonight. I know you were sick, but it also shows about your dedication to EMS and lifelong learning.